Hello, everyone. Now we will continue our session to epidemiology and social issue, and we will see three very interesting works pre-recorded. After that, we will have the time for comments and questions.
Hello all. We would like to thank the organizing committee for giving us the opportunity to present our work entitled Internet-Based Surveillance Systems on Smoking and Alternative Tobacco Product Use, Exploring the Potential of Twitter. All the participants of the study, Konstantinos Kesanopoulos, Christos Markou, Iana Karafilaki, Nefeli Gannapoulou Marini, Georgia Merkouriadi, Dimitra Papadaki, Vasiliki Athina Tirologou, and the Professor Anastasia Barbouni. We are members of the Special Academic Unit for the Study of Smoking Behavior of the Laboratory of Hygiene and Epidemiology of the Department of Public and Community Health of the School of Public Health, University of West Attica. Internet-based surveillance systems are increasingly used in the analysis, detection, and prediction of diseases and epidemics, as well as in forecasting human behavior on a variety of health topics. IBS utilizes a variety of data from different web-based sources to provide early warning, situational awareness, and to monitor issues of public health interest, such as tobacco and alternative tobacco product use, perceptions, and sentiments. According to Eisenbach's definition, epidemiology, which IBS implements, is the study of the determinants and distribution of health information. IBS systems are efficient and epidemiologically appealing and have shown a significant promise, as proven by the increase in recent publication and research regarding IBS and epidemiology. Epidemiology could be in great use to public health when trying to observe, describe, and present the people's perceptions and sentiments on various health issues, such as smoking and alternative tobacco product use. It could be a pathway or a motivating power for health professionals and patients to inform, empower, and act on smoking cessation, while IBS has the potential to provide input on the epidemiology, perception risk, and attractiveness of e-cigarette and other tobacco product use of Greek speakers. The aim of the study was to develop and evaluate a methodology collecting data to specify, present, and interpret the perceptions and sentiments of the population through specific hashtags regarding e-cigarettes in Twitter used by Greek speakers, native or not, globally. In other words, the data retrieved are meant to demonstrate the degree on which Greek-speaking Twitter users are interested in e-cigarettes. Smoking in Greece, even if present at constant degrees the last decade, remains a major public health concern. According to the latest data, approximately 1 out of 4 Greeks smokes. Tobacco use in Greece was reported by 28% of the adult population in 2020. Average cigarette use was reported by 27.2% of the adult population in 2017. IBS systems use all kinds of internet platforms or websites, including social media such as Twitter. Twitter is an information network made up of short messages, including photos, videos, and links, called tweets from all over the world. Registered users can post, like, and retweet tweets, but unregistered ones can only read those that are publicly available. As of the second quarter of 2021, Twitter had 206 million daily active users worldwide. As of April 2021, Twitter global audience was composed of 38.5% of users aged between 25 and 34 years old. A hashtag, written with a hash symbol, is used to index keywords or topics mainly on Twitter and other social media platforms. People use the hashtag symbol before a relevant keyword or phrase in their tweet to categorize those tweets and help them show more easily in Twitter search. Clicking or tapping on a hashtagged word in any message shows other tweets that include that hashtag. Google Trends, on the other hand, provides access to a largely unfiltered sample of actual search requests made to Google. It's anonymized, categorized, and aggregated. This allows us to display interest in a particular topic from around the globe or down to city-level geography. We proceeded to collect and analyze Twitter data regarding e-cigarette use and vaping. Although the target group was Greek speakers, we selected hashtags written in both Greek and English because the majority of them use both languages. In addition, English terminology is commonly used among Greek speakers. Moreover, we took into consideration the complexity of the Greek language that led to the use of different hashtags for the same words, such as with or without an accent mark, and an overall large number of possible hashtags. We developed a two-step methodology consisting from the word selection methodology and the internet-based surveillance system architecture. Regarding the lemma selection methodology, we used Google Trends alongside with Twitter to cross-reference the search significance of the lemmas and selected only those with high search appearance. Firstly, we searched a lemma on Google Trends and observed its search performance in Google. Given that its performance was significant, we searched the hashtag of the same lemma on Twitter for its performance in Twitter. Assuming that the search performance was significant on both platforms, we added the entry to the study. The eligibility and exclusion criteria of each lemma were then defined. Before retrieving the data, we set the time periods of the study, and then, when we retrieved all tweets, we classified them based on their user account. We developed an internet-based surveillance system, which we piloted on a social media platform. Twitter was our social media platform of choice. We developed and evaluated a methodology collecting Twitter data to specify, present, and interpret the perceptions and sentiments of the population through specific hashtags regarding e-cigarettes in Twitter used by Greek speakers, native or not, globally. We used Twitter's application programming interface and Twark2 to retrieve historical public data and tweets answering a specific query based on the word selection methodology. After sorting and processing them using Python and JavaScript, all tweets were stored in SQL databases. Healthcare professionals can access and use our system through a user-friendly web interface. The application calls for the necessary data and demonstrates them in histograms. After data retrieval, we processed them, stored them, and finally analyzed them. In the following graphs, you can see the results that occurred after running the IBS system. We noticed that throughout the years, hashtag vape with lowercase has been used much more than the other variants of vape. The fluctuation of the variance search performance during that given time period can also be seen in the graphs. Correspondingly, lowercase atmisma, which means vape in Greek, with accent mark has the same high usage throughout the years. On the contrary, hashtag atmisma without accent mark had an unsimilar usage between the 2 years. While conducting the analysis, we discovered that trends in Twitter hashtags differed from those in Google Trends. We assume this is due to the constructing number of users of each platform and also because the language used in Twitter is different than the one used in Google searches. Now we're going to look at the different types of users who showed interest in e-cigarettes, starting with the vape variants. We should not underestimate the role of commercial users as public health opinion makers. Thus, a concern was saved due to the large presence of commercial users who surprisingly seem to be as many as the individual ones. Comparing the results only from Twitter, having left out Google Trends, we have concluded that the information we get from Twitter using the keywords and their variants can lead to more complex and multi-theme analysis. On the contrary, the use of specific hashtags indicates the trending of one simple theme and may lead us to more results and better observations of the perceptions and sentiments of users thanks to their more targeted nature. Our methodology has some limitations, despite aiming at a conclusive, well-structured approach. Although we cross-reference the keywords with Google Trends, there remains a possibility of some of them being missed. Also, a number of tweets written in Greeklish A transliterated version of modern Greek using Roman characters is presumably excluded from our findings. Moreover, we cannot be sure whether the collected tweets were written by native or non-native Greek speakers, or whether they are residents of Greece and Cyprus or not. The proposed IBS system is an easy-to-use, user-friendly epidemiology tool for the surveillance of the perceptions and sentiments of Greek-speaking Twitter users. By using the developed IBS system, we were able to retrieve data from social media such as Twitter. According to the obtained results, the e-cigarette topic concerns the Greek-speaking Twitter users. The analysis of the data demonstrated trends of lemmas, hashtags, and keywords during the 2-year study period. This methodology is designed to be simple and user-friendly, thus it can be used by all healthcare professionals with or without programming skills. In addition, by gathering the content of Twitter messages through the use of special artificial intelligence algorithms, we will be able to have further information about the user's profile and a deeper understanding of it, which will possibly justify the fluctuations observed. Furthermore, there is potential of the methodology to be applied to other social media, such as Instagram and Reddit, or other products, such as heating tobacco devices. The proposed IBS system can provide valuable information for the design of public health prevention programs and smoking cessation targeted towards specific population groups, such as social media users. We would like to thank you for your attention.
My name is Prem-Kumar Shanmugam, and I'm speaking to you from Malaysia. I'm a psychologist by training. I'm also the clinical director for Solace Asia. We are an addiction treatment facility specializing in all kinds of addiction treatment, including substance addictions as well as behavioral addictions. The title for my talk today is Current Tobacco Control Policies and Observation of E-cigarette Use and Smoking Cessation among residents at a substance addiction rehabilitation facility in Malaysia, which is Solace. I would like to first talk a little bit about the tobacco control policies in Malaysia. Now, Malaysia has been a member of the World Health Organization Framework Convention on Tobacco Control, also known as FCTC, since 2005. Enforcement on tobacco products, particularly cigarettes, subscribe heavily to the 6 Empower measures provided by the WHO. Virtually all forms of tobacco advertising and sponsorship are prohibited by the law. Graphic health warnings on cigarette packs are mandatory, while terms such as light and low tar are disallowed. Now, the sale of tobacco products is prohibited to those under the age of 18. In addition, smoke-free regulations prohibit smoking in public places like restaurants, health and education facilities, and air-conditioned workplaces. Sub-national jurisdictions may enact even more stringent smoke-free laws. I would like to share now my slides on today's presentations. E-cigarette regulation and use in Malaysia. The prevalence of vaping is 5% among Malaysian adults. To compare, the prevalence of smoking is 21%. Now, the Malaysian government imposes an excise duty on e-cigarette devices and non-nicotine containing e-cigarette liquid since January 2021. Current legal provision only allows registration of nicotine containing e-cigarette liquid under the Poisons Act 1952 to be registered as a medicinal product for use in smoking cessation. A previous health minister in Malaysia announced a bill named Tobacco and Vaping Control Bill, also called the TVCB, to control all tobacco-related products and e-cigarettes to be introduced by early 2020. The introduction of the bill has been delayed by a change of the ruling parties in the government. To date, there is still no control on nicotine-containing vaping products, despite such products circulating in the market, and despite repeated calls from medical experts, vaping industry, and public for a defined control, including taxation and prevention of underage use. Smoking for substance use disorder. This is what I would like to talk about a little bit more. Research findings suggest a high comorbidity between illicit substance use and cigarette smoking. In the United States, more than half of adults with a lifetime substance use disorder diagnosis are current smokers. Smoking prevalence among patients in treatment for substance use disorder is 77 to 88%, which is reasonably high. Continuous cigarette smoking among patients is also associated higher as substance use disorder relapse rate. Therefore, it only makes sense to incorporate smoking cessation and prevention efforts into substance abuse treatment, which may improve long-term substance use outcomes for adult smokers with substance use disorders, while reducing smoking-related diseases and death in this group of patients. Let me show you a video and introduce you to Solace Asia, the first rehab facility in Malaysia, which started off with a scientific treatment approach. So this is Solace Asia, where we treat people suffering from substance use disorders as well as behavioral addictions. Next, I would like to talk about a case study. This case A. Up to 90% of patients have been smokers for at least 5 years, with an average of smoking at least 10 to 15 sticks per day. These are the patients who have come for treatment in Solace. Of late, I have begun to observe e-cigarette usage and its impact among residents at our rehab facility. As a number of our patients have been switching from conventional cigarette smoking to using e-cigarettes, I'd like to share 2 case studies here. Case A is a 33-year-old single male addict to methamphetamine for close to 13 years and presented to the center with delusional paranoia with hallucinations. At the time, we diagnosed him with substance-induced psychosis. He was smoking 20 to 25 sticks per day for the last 15 years. He underwent treatment with our residential clinical team for an initial period of 2 months. At the end of his stay at our rehabilitation center, he switched from smoking cigarettes to e-cigarette vaping and claimed he generally felt healthier. From a hygiene perspective, he shared he no longer smelled of cigarette. From a health perspective, he could smell and taste better while experiencing lower dependency to e-cigarettes. Overall, he felt he experienced more control over his health and habits. Now, post-discharge from residential treatment, Case A claimed to be free from methamphetamine abuse and psychosis and adopted a healthier lifestyle. He started going to the gym. He focused on healthy eating. He gained better self-confidence and maintained better relationships with family and friends. While he managed to stop smoking at 3-month post-follow-up from rehabilitation discharge, he was still using e-cigarettes. Now, I would like to now talk about another case, Case B. In addition, I have been observing a ripple effect in e-cigarette use among the residents during their stay at my facility. Case B is a 22-year-old married male who was abusing methamphetamine for 2 years and presented to the facility with symptoms of anxiety disorder. he was smoking cigarettes at a rate of 10 to 15 sticks per day for the last 5 years prior to admission. Although the patient voluntarily sought treatment at my rehabilitation center for his methamphetamine addiction, he was not motivated to quit smoking at all at the start of his stay. His smoking habits soon changed during his 2-month stay, being influenced by other residents who were vaping. At discharge, Case B claimed that he was confident he could quit methamphetamine use. He did not believe he could stop smoking until he started using e-cigarettes. Now, Case B has since joined a 1-month transitional treatment program, enrolled in the 9-month internship program at our facility as well. At the last follow-up, after being in treatment for close to 8 months, Case B was still using e-cigarette and had completely stopped smoking. Let me summarize the cases and make some suggestions for future studies. I observed several similarities between case A and case B. Number 1, both tried e-cigarettes due to perceived benefits to health and hygiene. Number 2, both maintained use of e-cigarettes for at least 3 months last follow-up. And number 3, both had stopped smoking since using e-cigarettes. Surely, the findings of 2 case studies cannot be generalized to other residents at my treatment center, but I believe current gaps in scientific evidence can be addressed by applying structured methods in collecting real-world data on e-cigarette use and smoking cessation among substance use disorder patients at rehabilitation treatment setting. There are emerging clinical evidences on the potential of e-cigarettes as a smoking cessation tool among general smoker population. Clinical trials can even be conducted to test the hypothesis that using e-cigarettes can lead to smoking cessation and prevent relapses in illicit substance use among substance use disorder patients. Alternatively, active surveillance on safety which follows subjects through a longer period can be more valuable than a controlled clinical trial of limited duration. Overall, data from rigorously conducted clinical trials and structured collection of evidence in real-world settings are valuable in informing decision makers of tobacco control policy in Malaysia, which is much needed now. As a closing, I would like to state, fellow participants, let me end by pondering these questions. 1, is zero tobacco or nicotine use a realistic goal of any public health authority? 2, if alternatives like e-cigarette can move smokers from smoking, can we give tobacco harm reduction a shot? And 3, after all, if we can move more smokers away, the morbidities and mortality associated with smoking, what do we stand to lose? I thank you for allowing me to present this, and I wish everybody to keep safe and stay well. Thank you.
Hello, everyone, and thank you for joining. I am Angela van der Plas, and I am Manager Real-World Evidence and Epidemiology at Philip Morris International. Today, I will be presenting results from our time trends analysis on hospitalizations for COPD and ischemic heart disease in Japan before and after the introduction of heated tobacco products. Smoking affects the health of individuals and populations. It has been estimated that if trends continue, 1 billion lives will be lost to smoking in the 21st century. Tobacco harm reduction refers to strategies that reduce the health risk associated with smoking, which may involve the continued use of nicotine-containing products. Heated tobacco products heat tobacco instead of burning it, and the absence of combustion translates into a reduced exposure to harmful and potentially harmful constituents. Philip Morris International's heated tobacco product is currently marketed as IQOS in over 50 countries. While these products are not risk-free, they have the potential to give smokers the chance to switch to better products. In this talk, we will present results of our first real-world evidence analysis. As heated tobacco products become available in different markets, it is important to assess their impact on the health of the individual and the population as a whole. Real-world data can be used to look for early signals of the population health impact of introducing novel tobacco products, for example, heated tobacco products, before epidemiological data are available. The aim of these studies was to describe the rates of hospitalizations for chronic obstructive pulmonary disease, COPD, COPD exacerbation, and ischemic heart disease, IHD, before and after the introduction of heated tobacco products in 2 Japanese databases. For these studies, we use data from the Japan Medical Data Center, which is an epidemiological receipt database that includes 7.3 million subjects. JMDC contains disease procedure diagnosis or DPC data by which the reason for hospitalization is classified under a flag, for example, main disease or causative disease, and inpatient data which are not categorized by a flag and are overall more abundant. The second database was the Medical Data Vision, MDV. This database contains hospital admissions using ICD-10 codes for COPD, COPD exacerbations, and ischemic heart disease. This database includes health claims data from over 300 Japanese acute hospitals, including records for over 20 million subjects. The hospitalizations from 2013 to 2019 were aggregated by month and year, with admissions per ICD-10 code category expressed as a percentage of the total of admissions. Different models using ITS, or interrupted time series, allowed us to test the hypothesis that the introduction of heated tobacco products is associated with change in hospitalizations in terms of the intercept, mean change, and slope, changing speed. It's also flexible for adjusting for different confounders. For this analysis, we used 2 types of event definitions. The first one was a no-flag analysis, including all data, and the second one had only DPC data included using the causative disease flag for hospitalizations. The cutoff point was based on previously published sales data, and since heated tobacco products were introduced into the Japanese market late in 2014, it could be assumed that there is a 2-year lag period. Now, let me show you the results. These are the data counts by endpoint by year. The study period included was from 2013 to the year 2019. Because data coverage increased substantially between 2012 and 2013. Because of the very low counts of events in the DPC data, the only analysis done using it was for the ischemic heart disease endpoint. The study period included was from 2013 to 2019 because data coverage increased 49% between 2012 and the year 2013. Both MDV and JMDC databases contain different populations. For instance, the JMDC database contains younger enrollees and a larger proportion of females than the MDV database. In terms of number of hospitalizations, the JMDC database has around 1/4 of those included in the MDV database. Additionally, due to the low number of COPD exacerbations in the Japanese population in general, we added the endpoint of COPD plus lower respiratory tract infections in order to have comparable data to that seen in the MDV database. This slide shows the MDV database analysis on COPD hospital admissions adjusted for age and sex. Using the MDV data, we see a small decline in the hospitalizations due to COPD after the introduction of heated tobacco products that was not statistically significant. This slide presents the interrupted time series model adjusting for age and percentage of females using all data for COPD hospitalizations using JMDC data. The cutoff point of introducing heated tobacco products was set at January 2017 based on previously published sales data. Hospitalization rates for COPD adjusting for age and sex were significantly lower than expected. Further adjusting for other covariates such as influenza vaccination coverage and seasonality did not alter the results. The analysis for COPD exacerbations using the MDV database showed that hospitalization rates adjusting for age and sex were significantly lower than expected. Further adjusting for the covariates such as influenza vaccination coverage and seasonality did not alter the results. This slide shows the hospitalizations for COPD exacerbations, including lower respiratory tract infections in those with COPD. We observed no significant change in trends after the introduction of heated tobacco products. We also observed a small decline in the hospitalization rates for ischemic heart disease, and although the decline was not significant, it makes sense to reevaluate this endpoint after a longer follow-up post-introduction of heated tobacco products in the Japanese market. The analysis using all data from the JMDC database found a decline in the hospitalization rates for ischemic heart disease that was not statistically significant. For ischemic heart disease hospitalizations using only DPC data, we can observe an immediate increase in the rates post-heated tobacco product introduction that was statistically significant, followed by a change in slope post-heated tobacco product introduction, which was significantly different from the expected increase in trend. The analysis of the MDB data showed a significant reduction in the rate of hospitalizations for COPD exacerbation after the introduction of heated tobacco products in Japan. Small declines in the hospitalization rates for other smoking-related diseases were observed, for example, COPD all codes and ischemic heart disease, although they were not significant. The analysis of the JMDC data using all available data showed a significant reduction in the rate of hospitalizations for COPD all codes after the introduction of heated tobacco products in Japan. The small declines in the hospitalization rates for COPD exacerbation, COPD plus lower respiratory tract infection, and ischemic heart disease were not significant. The analysis, restricted to DPC data only, showed a significant reduction in the rate of hospitalizations for ischemic heart disease. Data regarding COPD endpoints were scarce, hence no meaningful interpretation can be drawn. There was a significant reduction in the rates of hospitalizations due to COPD after the introduction of heated tobacco products in Japan, when using all data, and due to ischemic heart disease when using DPC data only. Time trends analysis focus on populations, but can be a useful tool in detecting potential associations between heated tobacco products and smoking-related diseases. While tobacco use history is not captured in detail in hospital records, this analysis detected some encouraging trends in smoking-related disease hospitalizations in Japan, which show the same trends as our previous study. Finally, there are many limitations to this type of research, such as no subject-specific data including specific exposure, and it is important to mention that the results do not indicate a causal relationship. Thank you very much for your attention.
It's a great pleasure to be with you at the 4th Scientific Summit on tobacco, speaking on tobacco harm reduction, novel products, and the research and policy. I've spent a lifetime working towards a smoke-free future, as has Professor David Kayatz. I'm going to talk today about the history of where we've come from and where we still are, and how we have to help the patients who are continuing smokers to quit or to reduce the harm of continuing smoking. Let's look at the situation in the UK. The government target is to be smoke-free by 2013, and they define smoke-free as less than 5% smoking prevalence amongst adults. We're not on track to meet this target. There's wide variations in smoking prevalence across this country, great inequalities, and Cancer Research UK says that we won't be smoke-free until at least 2037. And a personal view is it's going to be longer than that. The tobacco control strategies in education have worked, and I'm going to show you that. They've significantly decreased the prevalence of smoking in the UK and worldwide, but there still remains a significant number of smokers. The left-hand panel that you can now see looks at the history in the UK of smoking reduction. And you can see through the 60s, 70s, 80s, the 2000s, 2020, that we have significantly reduced smoking rates. And that's due to various fiscal and other policies. We stopped advertising, We've increased the price of cigarettes, but you can see there are plateaus in these significant decreases in smoking prevalence. Nevertheless, 14% of adults in the UK continue to smoke, and that is estimated at 6.9 million continuing smokers. If we look at how smoking disproportionately falls on the underprivileged, this slide shows it. If you look at the left panel as you're looking at the screen, you can see that professional and managerial classes, we've reduced smoking to 12%. But as we go down and we look at workers in labourers and bar staff, you can see it remains at 28%. So there's very significant disparity where our lessons concerning smoking are sitting and who has responded. So we have to ask, what can we do? Can we do anything? Can we do nothing? Should we continue to say, it's up to you, quit or suffer the consequences? Well, you can look on the next slide at what might be prohibition, eliminate smoking. And we tried that with alcohol in the United States in the 20s and 30s. And I think all of us know that alcohol continued to be taken. Tobacco control aims to influence behavior rather than ban it. Policies vary by country, and the Global Convention entered into force in 2005, said we should all look at this as a group of nations trying to drive down smoking together. Currently, there are 181 parties in that convention. So we have to say, does it work? Let's look at another issue we had and whether that worked. So we had the problem of harm reduction during the AIDS epidemic. And Mrs. Thatcher, our Prime Minister in the 80s, was not known for much for her kindness or thoughtfulness. However, she did sanction, during the AIDS epidemic, needle exchanges and safe havens, giving us the lowest rates of HIV in drug users in the world. So over the past 12 years, the UK think tank Centre for Social Justice led change in that drug policy, saying we should have an abstinence-based policy. And unfortunately, the drug-related fatalities have doubled since 2011. And now, from the lowest rate of drug-related fatalities in Europe, 1 in 3 drug-related deaths in Europe are now in the UK. So what I come to as a statement from this is people make poor lifestyle choices despite suffering negative health effects. And the headline in the Times in September the 2nd, 2019 was, "Misguided morality is denying help to drug addicts." So there's many ways of looking at what in Britain is still an illegal process of drug addiction, intravenous drug addiction, and yet you must help and prevent those terrible diseases that can spread with infected needles. So let's look now about quitting tobacco. Quitting tobacco smoking is by far the best option. But we have to look at whether innovation of less harmful alternatives could play a role in harm reduction. That is saying, you shouldn't smoke. I don't want you to smoke. I'm going to ban smoking in public spaces. I'm going to ban smoking in cars. If you have children with you, I'm going to ban smoking in transport. But nevertheless, we have to play a role in trying to find less harmful alternatives. So the innovations that have come in, of course, we all know about, are the e-cigarettes and heated tobacco products. So in this way, the smoker will have nicotine and will not die of the products of combustion. So cigarette smoke causes diseases, including cancer. We all know that. As I said, it started with that very good paper in the doctors in Britain run by Dolan Hill. Burning tobacco generates smoke. Tobacco smoke has over 6,000 chemicals in it. It contains ultrafine particles. 93 of these are listed by the USA FDA as harmful and potentially harmful constituents. The majority, almost 80, are carcinogens or potential carcinogens. So there we have it. You should not smoke. You must not smoke combustible cigarettes. What can you do with these new products? Are they only a substitute, or could they help you stop smoking? So there has been a Cochrane review, and these Cochrane reviews are very thorough. And the heading of the Cochrane review is Electronic Cigarettes for Smoking Cessation. The review, which was updated in April of this year, included 56 completed studies. It represented 12,800 participants, and 29 were in randomized clinical trials, the gold standard. The conclusion of the Cochrane review is there is moderate certainty evidence, so everything is small numbers and we have to interpret the data. There's moderate certainty evidence that electronic cigarettes with nicotine increase quit rates compared to electronic cigarettes without nicotine and compared to nicotine replacement therapy, which is what we essentially had before. We did not detect, the authors say, any clear evidence of harm from nicotine electronic cigarettes, but longest follow-up was 2 years, and the overall number of studies was small. So no one's saying we've got complete guarantees, but we're saying at this early stage, the evidence does point in the right direction. We also have other evidence, and this has come from the FDA in America, which reviewed all the evidence concerning heat-not-burn product, IQOS. It determined that the exposure modification order for IQOS would be appropriate. So you could start to market IQOS to promote the public health, and it is expected to benefit the health of the population as a whole. They state the obvious: no combustion in IQOS. IQOS emitted reduced levels of toxicants than cigarettes. And if we look to the right-hand panel, you can see that acrolein is down by greater than 90%. The benzpyrenes are down by 90%, formaldehyde down by greater than 80%. The nicotinoids down by 92%, and the ketone nicotinoids down by 98%. IQOS has a lower toxic potential than cigarettes, and although risk reduction has not yet been demonstrated, a substantial and measurable reduction in morbidity and mortality is reasonably likely in subsequent studies. So FDA made a pretty powerful statement there. They looked at the evidence, they've reviewed the evidence, they've remeasured the evidence, and they do think that there's evidence that it's contains significantly less toxicants. So if we look at this adapted from Stevens in 2017, and we look at the mean lifetime cancer risk ratio to smoking, and we put at 1 cigarettes to the right of the screen, you can see that nicotine inhalers are down at 0.000, that e-cigarettes are very adjacent to that, and that heat-not-burn products are very adjacent to that. So he said the cancer potency is not really a risk continuum, it's not really a gentle slope, but a risk cliff. So at the levels which you are having from these products, it does look as though there's going to be much lower risk. How do we end this talk? It's clear that we have to encourage quitting. It's clear that smoking is not good for you. But we have to answer the needs of a population who cannot or will not quit. So we have to approach harm reduction in this position, just as we did with other subjects, just as we put in seatbelts in cars and airbags in cars to protect you from collision. We need to cut through the confusion and rhetoric. We need to address the needs of continuing smokers. We need to help as many of them as possible to stop smoking cigarettes. We've got to protect the youth from exposure to and the use of these products. So we have to look very carefully at whether these products could be a pathway into smoking combustible cigarette smoking. There's no evidence for that. The products have been looked at very carefully. A spectrum of products is needed with regulation in place that is proportional to the risk of those products. Sales and advertising of the products has to be restricted to legal age users. You must allow accurate and truthful information and warnings relative to cigarettes that consumers understand. You therefore need to accept that these products have a role, and then you need to control how we market and sell these products. But I think the end result will be a better place, and that of the remaining smokers, and I've said in the UK 7 million, of those remaining smokers, we should be able to reduce their risk and help them to avoid disease. Thank you.
To begin, thank you to the organisers of the conference for the opportunity to present our work investigating the impact of the COVID-19 virus and related policy responses on smoking and nicotine use. The study was funded with a grant from the Foundation for a Smoke-Free World, a US non-profit 501c3. The full funding statement is available on this slide. Also, myself and my colleagues at BOTEC have consulted for firms in the tobacco industry, as well as regulators and philanthropic research funders. The link between stress and nicotine consumption is well established, and for many the prospect of illness and death, enforced isolation, and economic downturn that COVID brought has made life stressful. It stands to reason then that the pandemic has affected the use of tobacco and nicotine. Additionally, a reduction in time spent in areas where smoking is banned and changes in free time and disposable income may have increased consumption of tobacco and nicotine products like e-cigarettes. Conversely, reductions in disposable income, heightened attention to health and well-being, and less time spent around environmental triggers, and more time spent around non-smokers may have decreased consumption. These possibilities are not mutually exclusive, and both effects may have occurred simultaneously in different subnational groups. Governments' responses to the pandemic likely also affected the availability or perhaps accessibility of products, and misinformation about the interaction between nicotine and the virus could have changed consumers' perceptions of risk. During COVID, pre-existing tobacco restrictions have been extended ostensibly to protect public health, or at least safeguard the provision of health services and reduce opportunities for viral transmission. Spain's extension of their smoke-free regulations serves as one example. However, there have also been novel restrictions affecting tobacco and nicotine. The restrictions on international travel functionally denied duty-free sales to most smokers. The general restrictions on businesses, including limits on operating hours and capacity, and forced closures of non-essential businesses may have further reduced product accessibility. In some contexts, vape stores were deemed non-essential and shuttered, at least for a time, while stores such as grocers and gas stations, which often sell cigarettes, remained open. Finally, there have been specific restrictions on tobacco and nicotine products, such as the restrictions on online purchases enacted by France. But the most extreme example of specific tobacco restrictions during the era of COVID come from South Africa and Botswana, where the sale of cigarettes and alcohol was banned during the spring and summer of 2020. COVID-19 messages have also quickly been absorbed into the stop smoking campaigns, including this one by the World Health Organization. We conducted a structured review of the existing literature to investigate changes in the prevalence and frequency of the use of combustible tobacco and safer nicotine products. Surveys focusing on behavioral adaptations and changes to beliefs, attitudes, and motivations were also included. We processed 352 articles in all, extracted from the PubMed database during April of 2021. Inclusion criteria, displayed on this slide, were designed to maximize inclusivity. This analysis is not intended to establish causal relationships, but to suggest associations that might then be explored further as better quality data emerges. There are a number of limitations with the data. In general, many of the surveys are unlikely to be representative of the wider population, and the reliance upon online survey data creates the risk of recall and reporting bias and social desirability bias. The literature also acknowledges that in the rush to publish, the analytical methods of some studies may be substandard. This may be particularly true of cohort studies in clinical settings, where the accuracy of patient records may be imperfect. Granted, the challenges of providing healthcare in patient settings during the pandemic may make for difficult environment for data collection. Still, much of the survey literature pertains to the first few weeks or initial months only of the lockdowns, and the ultimate effects of the pandemic may not emerge until much later. It's also unclear whether and for how long observed changes will persist. Time series cohort studies could help answer these questions. Smokers exhibited a bifurcated response in the majority of sources reviewed, approximately 67%. Increased consumption appears to be reported with significantly greater frequency than decreases. Additionally, the extent of the increases appears greater than decreases. Among studies reporting increases, 2/3 reported that increases in smoking frequency were greater than 25%. Conversely, just 13% reported decreased smoking frequency in the same proportion of smokers. 59% of sources reported that the pandemic had increased smokers' motivation to quit or reduce smoking, while 22% also stated that COVID had reduced these motivations among some smokers. Changes in prevalence were less widely reported. Only a handful of the sources reviewed discussed changes in smoking prevalence explicitly. However, there was evidence for both increases and decreases in prevalence driven by the pandemic. So this chart shows the various increases and decreases in smoking frequency reported by the studies identified, with the green bars showing the net effect. A similar bifurcated response was noted among e-cigarette users. Again, increases tend to outweigh decreases in about 3/4 of the sources, and the pandemic also appears to have increased motivation of e-cigarette users to quit or reduce consumption, with increased motivation reported in between 5 and 40% of survey respondents. And again, this chart shows the difference between increases and decreases in frequency of e-cigarette use reported by the studies. Again, the green bar shows the net effect. The literature identifies a number of local environmental phenomena and individual factors that were consistently associated with increased consumption. These include stress and anxiety, isolation, worse mental health, and greater fear of infection, as well as greater nicotine dependence. And generally, the picture this paints is one in which the worst smoking-related COVID responses are concentrated among those who are historically disadvantaged, as may be true of COVID harms in general. And this suggests that COVID-19 may have exacerbated existing smoking-related health disparities. Interestingly, individual-level associations appear to operate in surprising ways in different contexts. For example, given that unemployment has been associated with smoking status, it's perhaps surprising that in Italy and the US, an improvement in smoking habits was associated with unemployment during the pandemic. And it might be that increased free time, or perhaps more time spent around family members as a result of a loss of or a reduction in formal employment, confounds the stress effect. And this topic requires further investigation. The availability of combustible tobacco at essential businesses, coupled with the closure of many vape stores, may have made e-cigarettes harder to obtain than conventional tobacco, and this may have nudged consumers of safer nicotine products back to cigarettes, reversing the public health gains from the original substitution. The duration and extent of this effect requires further analysis. Product bans, such as those enacted by South Africa, do not extinguish consumption. One source estimated that 93% of smokers simply transition to illicit sources, and the consequences of greater illicit trade include lost revenue, $100 million a month according to one estimate, as well as rising enforcement costs at a time when public spending is already being stretched. Illicit markets also bring violence and deny regulators an opportunity to oversee a minimum level of product safety. Ostensibly, the motivation for South Africa's ban was to minimize the risk for viral transmission, but the sharing of newly scarce tobacco and the absence of social distancing during illicit transactions suggest that the risk of tobacco-related COVID transmissions may have been increased by the ban. While social distancing protocols appear to have been effective at flattening the curve, future lockdowns should consider possible unintended consequences, such as increases in risky behaviour, and account for them in prospective cost-benefit analyses. To support smoking cessation efforts, vendors of safer nicotine products should be designated as essential businesses. Businesses where combustible tobacco products are sold could also be encouraged to offer SNPs alongside combustible tobacco. if public health officials deem the closure of stores selling SNPs to be necessary, restrictions on online sales to age-verified adults should be avoided. Tobacco taxes should be pursued with reference to increased illicit trade. Taxes should be applied only to combustible tobacco, or at least designed to treat SNPs favourably in comparison. One of the remaining knowledge gaps on this topic relate to COVID's effect on second-hand smoke levels. Did being at home make smokers cut down, or did it expose their families to greater levels of second-hand smoke? This needs to be investigated. Post-pandemic, regulators might consider strengthening smoke-free rules to reverse any effect of social distancing and remote working on smoking. But as remote work is likely to continue, additional ways to discourage smoking in the home will need to be identified. Priority should be given to reduce second-hand smoke exposure in shared and public housing, communities in which smoking rates are often higher. And to encourage compliance, regulators might consider designing smoke-free laws that treat safer nicotine products favourably in comparison to combustible cigarettes.
Hello, my name is Vivencio Barrios. I'm a clinical cardiologist. I'm working at the University Hospital Ramón y Cajal in Madrid, Spain. And it's my honor to present you this oral communication focused on the Habitat project, a project to study the smoking habit among patients and faced with their withdrawal. According to a national survey, the EDADES survey, performed in 2019 and 2020, in Spain, the percent of smokers who do not consider quitting is between 37 and 40%. And unfortunately, this is increasing. Thus, despite intensive healthcare campaigns, we could say that the strategies to quit the smoking habit are frequently unsuccessful. And among certain group of patients, this is especially difficult, this is especially uneasy. Well, with this idea to check how is the smoking habit in different population of patients, we performed the Habitat project, a project promoted by the Spanish Patient Forum and with the collaboration of the Aragonese Association for Mental Health, the Association of Coronary Artery Disease Patients, and the National Federation of Associations of Respiratory Diseases. Thus, the objective of the study was to study the smoking habit in 3 groups of smokers belonging to these 3 patient associations, aimed to analyze the consumption, the degree of addiction, the history of withdrawal, and the motivation of it, as well as future proposals. From March 2021 to 2021 and to May 2021, patients answered an anonymous electronic questionnaire, which was endorsed by the Spanish Society for Healthcare Quality, the SECA Society, and was approved by the Research Ethics Committee of Camilo José Cela University in Madrid, Spain. We had the special collaboration of Philip Morris, Spain. This is our study population. There was a study of 111 patients, 37 patients per each group of subjects. And as we consider that we had a heterogeneity of 50% and a confidence level of 95%, the minimum sample we calculated should be of around 97. And this will represent a sample error below 10%. We perform a competitive recruitment, so the first 37 patients for each subset of subjects who respond and completed the questionnaire were included in the analysis. So we have a homogeneous group of patients from mental care, healthcare, from coronary artery disease patients, and from respiratory patients that completed the Habitat project. Concerning to the results, there were 111 accessible smokers or ex-smokers, 37 from each study group, with a mean age about 61, 62 years. Almost half of the patients, 49% to be exact, were currently smokers, and with an average of 17 cigarettes per day of consumption, and with a history for more than 28 years. The yearly PAX index was over 24, and the mean Firestrom value was 4.26. When we checked the motivation to quit smoker, the main motivation was awareness of the damage of their health. However, 39% of these subjects, of these patients, didn't want to quit smoking. Only 19% will try to stop in the coming weeks. So the proposal was not optimal, was far from optimal. And 91 tried to stop the habit at some time, but 69 have relapsed, mainly due to stress or anxiety. More than half of the patient, almost two-thirds of the patient, 74%, but also due to just dissatisfaction for a smoker in 13% of these subjects. 60% try to quit by themselves with any kind of help, and only 33% turn to a health professional, evaluating the effectiveness of the available supports as low, really, and actually very small. Here are the support strategies that people claim: the individual psychological therapy, the group psychological therapy, the nicotine patches or gum, medicines, electronic cigarettes, or other kind of means. But the success was not high, as you could see, because a lot of them continue going smoking. So the conclusion, very briefly, the population should be undoubtedly discouraged from smoking, and we should promote educational campaigns against tobacco use. These campaigns, these strategies are mandatory nowadays, but for those subjects who are already smokers, and seems that quitting it seems that quitting is an unattainable goal for many people. It's not easy, and many of them do not want to stop the habit. So in this case, try to reduce the harm of traditional cigarettes. Exploring alternatives and several devices becomes a regional approach. And I think we could support this kind of alternatives to those patients who do not want to quit quit smoking, or for those subjects who simply cannot quit smoking. Thank you very much for your kind attention.
This research, produced by Bowtech Analysis on correlation, causation, and selection bias regarding e-cigarettes and smoking, was performed by Anna Choi from Sejong University and me, James Prieger, from Pepperdine University. This research was funded with a grant to Bowtech Analysis from the Foundation for a Smoke-Free World. The research and opinions I present are the sole responsibility of the authors. Regarding conflict of influence, I have consulted for firms in the tobacco industry in the past regarding ends and illicit trade. From 1980 to 2018, the prevalence of smoking among men in Korea declined from 80% to under 40%. Despite this achievement, the overall smoking rate in Korea remains above the median for all countries, and male smoking prevalence is still among the highest in the world. The reduction in smoking in Korea has been accomplished largely by means of the standard tobacco control playbook: tobacco taxes, publicly provided cessation services, smoke-free laws, and so forth. However, there is evidence suggesting that the efficacy of at least some of these policies is decreasing. For example, after the last large tax increase in 2015, the smoking rate dipped for men, but the following year it rebounded. There is yet much room to further reduce smoking in Korea and improve public health, and new approaches to encourage cessation from smoking should be considered. The widespread availability of e-cigarettes, ends, and heated tobacco products in recent years are the most innovative aspects of Korea's recent experience with tobacco, nicotine, and cessation. It is highly likely that ends are significantly less harmful than cigarettes. Ends have also been found to aid cessation in some studies, including randomized controlled trials. What promise might ends hold for the harm reduction and cessation from smoking in Korea? In contrast to an increasing body of international public health experience and literature, the Korean government has made it known that it considers ends to be just as harmful as cigarettes, and that ends should not and cannot be used for cessation. As a result of negative views about ends by the government and the media, ends use is low in Korea compared to many other countries. Korean tobacco policy also fails to differentiate meaningfully between ends and traditional tobacco products in terms of taxes or most regulations. This removes important incentives for Korean smokers to reduce the harms from their mode of nicotine consumption. This might represent a massive lost opportunity to reduce smoking at a time when its decline has slowed. The government's stance relies in part on the fact that many ends users also smoke, making it appear that ends lead to smoking, support the smoking habit, or hinder quitting. However, the positive correlation between ends use and smoking is not likely to reflect a causal link on average, since unobserved factors that increase the likelihood of smoking may also increase the chances of using ends. Investigating this was a major part of our research effort. Our evidence for such selection effects in who chooses to use ends comes in several forms. First, we compared data before and after a highly publicized negative government report on e-cigarettes and a tax increase on them in 2015. We find that the demographics and health behavior of ends users changed in ways unfavorable to cessation. This is evidence that the government's negative messaging about ends changed who was using them toward those finding it hardest to quit smoking. Second, the positive correlation between ends and smoking also rose markedly. Third, estimation of an econometric model designed to correct directly for sample selection bias shows that ends may indeed causally improve the likelihood of quitting smoking. In particular, we had estimated econometric models for endogenous treatment effects to correct for that selection bias. Our framework goes by many names in the econometric literature, but basically it is a double binary dependent variable system, two main equations. It's recursive in the sense that the e-cigarette usage appears in the equation for cessation, but not vice versa. And it is a linear index threshold crossing model in the same way that a probit or a logit is. So in the equations here, you can see that the first pair are to describe an individual's behavior regarding the propensity or whether they actually use e-cigarettes. The second pair of equations is for the outcome equation. And so when we speak about treatment using the treatment effects literature nomenclature, that refers to using e-cigarettes or not, and the outcome has to do with cessation, quitting smoking. The observation rule is that the dependent variable y equals 1 if the person had smoked at some point in the past, but has now quit smoking. The quantity of interest that we are trying to estimate with our modeling is the average treatment effect on the treated, or the ATET. This is the causal impact of e-cigarette use on the likelihood that someone has quit smoking among those who chose to use ends. And so this is not the average treatment effect across the whole population, because that would be more relevant if we were thinking about randomly sprinkling e-cigarettes throughout the population. Instead, we have to respect the fact that people choose to use them, and we want to estimate the treatment effect for such people. We estimate many versions of this model. One is a bivariate probit model that has independence between the two equations. This would assume away selection effects and is our base case. Then we do a bivariate probit model with allowing for unobserved confounders to be captured by the error terms in the two latent equations. This allows for selection effects. And then finally, we re-estimate versions of that two equation model using copula modeling to check the robustness of the assumptions. So here are the first set of results. In these models, we are trying to estimate the average treatment effect on the treated, recall, which specifically is how does the probability of cessation change with e-cigarette use due to the causal effect. Now, in these specifications here, I know that there are a lot of numbers, but note that in the first row, the simple probit model that assumed away selection effects finds that ends use, quote, leads to less cessation. That's the negative ATET of negative 0.147 that you see there. However, in every other model that allows for selection effects, the ATET switches sign, and significantly so. There are many models here. Let me just say that we use formal information criterion, the design-based AIC measure, to pick a best model. And that best model is one of the copula models down there at the bottom. And our estimate of the causal effect from this model of using e-cigarettes on cessation is 16.2 percentage points. We also estimated a second set of models using the so-called potential outcomes specification. This essentially allows all the coefficients in the outcome equation to take different values depending on whether the person uses e-cigarettes or not. And so these models nest the simpler models on the previous page. And again, we modeled things many different ways. Note again that the treatment effect is estimated to be positive and statistically significant in all cases. And again, using our design-based AIC measure, we are led to that Clayton copula model as the best specification, and a result remarkably similar to before, about a 16 percentage point impact on promoting cessation, we estimate, from using ENDS. And then we estimate a different model down at the bottom. It's not a likelihood-based model, and so we can't directly say which one is better by the AIC measure. This is a control function model. It's a generalized method of moments estimation method. Details are in the paper, but again, a completely different method, but we find a very similar result, this time about a 17 percentage point impact on cessation from using ENDS. In summary, there is evidence that the individuals least likely to quit smoking are those taking up ENDS in Korea. Second, unobserved confounding factors associated with more ENDS use and more smoking account for the positive correlation observed between the two. Third, correcting for the observed and unobserved differences between ENDS users and others reveals that ENDS may help smokers achieve cessation. And four, there is therefore a potentially severe selection bias in any observational study of the association between ENDS use and smoking. Thus, the common belief among public health officials in Korea that ENDS use is hindering cessation is likely based on faulty conclusions drawn from inadequate analysis of the data. And now I leave you with a few brief policy recommendations. First, evaluate the impacts of tobacco control practices and ENDS usage with appropriate methodology, especially if one intends to make statements about causality. Second, consider and study the role that ENDS can play in harm reduction for adult smokers. Thank you, and I look forward to your comments and questions now.
I'd like to begin by thanking the organizers of this conference for giving me the opportunity to present this work, Alternative Nicotine and Smoking Cessation, Findings from Case Studies in 5 Countries. I'd also like to note at this point that the case studies from which I'm summarizing were the product of a collaboration between researchers from several institutions, including my firm, Botec Analysis, and Pepperdine University, the Transcrime Institute at the Università Cattolica in Milan, and the Concordia University in Canada. The study was funded with a grant from the Foundation for a Smoke-Free World, a US non-profit 501c3. The full funding statement is available on this slide. Also, both myself and my colleagues at Botec have consulted for firms in the tobacco industry, as well as regulators and philanthropic research funders. Smoking and related harms are concentrated, both in national and subnational contexts. Regulators hoping to encourage cessation may therefore be tempted to gain inspiration from countries with strong track records, reducing the prevalence of smoking in their population. However, no country has succeeded in eradicating smoking entirely, and this suggests that even perfect replications of the best performing tobacco control policies will not do so either. The goal of a smoke-free future would seem to require something else, not to replace traditional tobacco control, but to augment it. Many nations with the best track records of smoking cessation have seen recent successes coincide with the introduction of alternative nicotine delivery systems such as e-cigarettes and heated tobacco products. The evidence confirms that these products are indeed substitutes for combustible tobacco, and a growing number of RCTs confirms that ANDS are effective cessation aids. Moreover, emissions tests suggest that the product may expose the consumer to an order of magnitude less risk compared with smoking. However, smoking and quitting are also culturally dependent. So what does the empirical evidence tell us about the nature of the relationship between ANS and smoking cessation in different national contexts? Do those products help or hinder tobacco control? And how has the regulation influenced that dynamic? This paper draws upon a series of 5 case studies looking at the drivers of cessation in Australia, Canada, Japan, South Korea, and the UK. The studies deploy a mixed methodology combining literature reviews with analysis of trends in national cross-sectional data, media analysis, and econometric investigations. The reports were produced by an international team of researchers representing multiple disciplinary backgrounds, including sociology, economics, psychology, and policy analysis. The focus of each analysis was both national and subnational. The case studies identify 4 historical pillars of tobacco control, each of which has contributed to smoking cessation. Awareness of harms has been driven by the scientific study of tobacco and smoking, the provision of medical advice, public health messaging, and mass media campaigns. Awareness of harms appears to have driven cessation even prior to the introduction of coherent tobacco control policies, suggesting that, for some, this motivation alone was sufficient to produce quitting attempts. Tobacco control policies including taxation, smoke-free laws, ad bans and age limits, as well as stop smoking services and the provision of nicotine replacement therapies, have all aided cessation. However, while each of these pillars has driven cessation effectively, none has done so completely. Awareness of harm's effect on cessation is limited by cognitive dissonance. Many of today's smokers know full well how bad tobacco is for them. Tobacco control policies have reduced opportunities for smoking and made doing so less appealing, but they have failed to provide smokers with a mechanism with which to quit. Stop smoking services are limited by funding cuts and underwhelming engagement, and nicotine replacement therapies provide an imperfect analogue for cigarettes and are further unpopular because they're seen as a medical solution to what few smokers themselves consider to be a medical problem. This slide summarizes the current use of ANS in our case study countries, as well as a simplified description of each nation's regulatory position. The use and regulation of ANS differs widely between national contexts. Note that Canada and the UK have regulations which favour e-cigarettes compared with heated tobacco products. Accordingly, the use of e-cigarettes is significantly higher there. Conversely, in Japan, where heated tobacco products are regulated on parity with cigarettes and e-cigarettes are banned, heated tobacco products are more popular. However, note also that the ban on e-cigarettes in Japan and the ban on ANS in Australia has not eliminated use. The next 2 slides go into some more detail on the UK specifically. This slide presents the prevalence of adult smoking in the UK since 1974 and some of the more significant events in tobacco control over that timeline. Note the periods where cessation appears to have stalled in the late 1990s and the early 2000s, as well as the late 2000s, early 2010s, prior to the growth in popularity of e-cigarettes from approximately 2014 on. The graph on the left shows the co-occurrence of smoking cessation and the uptake of e-cigarettes in the last decade, while the graph on the right shows the prevalence of e-cigarettes use among current and ex-smokers between 2014 and 2019. Note that while the use of e-cigarettes among current and former smokers rises, use by never smokers remains at or around 1 or 2%. So what lessons from these 5 countries? Well, firstly, regulatory decisions matter. Product bans do not eliminate consumption, as we've seen with Australia and Japan. However, consumption is informed by regulators and their stated preferences. The creation of regulatory differentials between different product categories is reflected in the consumption data, and regulatory differentials between ANS and combustible cigarettes regarding perhaps taxation, smoke-free laws, and perhaps marketing restrictions would likely influence consumption as well. Secondly, consumers overwhelmingly use ANS to reduce or quit combustible tobacco. That is confirmed again in the consumption data, as well as qualitative surveys of ANS users. And that suggests that ANS owe their popularity, at least in part, to the legacy of traditional tobacco control. Another key finding from the case studies is that cohort studies often underestimate ANS efficacy on cessation because users are primarily constituted of current smokers and those who have demonstrated an above-average resistance to tobacco control policies. Controlling for that bias, as has been corroborated by RCTs elsewhere, demonstrates that ANS cessation efficacy may surpass that of popular NRTs. tobacco harm reduction critics have been concerned that ANS could renormalize tobacco use, either by serving as a gateway to combustible cigarettes or perhaps by delaying quitting attempts. However, recent reductions in smoking prevalence, which have occurred while, if not actually because of, the uptake of ANS, and indeed have occurred at a time while ANS were relatively unregulated in many contexts, serves to assuage this concern. Critics have also been concerned about the rise of youth experimentation, and those concerns have played out in Canada. But while the rates of ever use have indeed increased, rates of youth smoking have collapsed. Furthermore, the fact that ever use does not seem to be translating into current use among youth in all contexts suggests that there may be regulatory levers or other contextual features which can be used to effectively discourage vaping among non-smoking youth. More research is needed on this topic. Finally, far from undermining traditional tobacco control, there is evidence that ANS complement pre-existing regulations. An analysis of data from the EU conducted in 2018 by Dr. James Prieger and some of the other case study authors suggests that the availability of e-cigarettes there attenuates smokers' tendency to respond to tobacco taxes by embracing the illicit market. And this suggests that ANS would allow for greater levels of tobacco taxation than would be possible or desirable previously. There is also evidence from the UK that the provision of e-cigarettes to public housing clients is fostering greater compliance with smoke-free laws. Finally, figures from the UK suggest that, since e-cigarettes have been available, the numbers of NHS-funded prescriptions for pharmacotherapies and public expenditure on stop smoking campaigns has declined significantly without a commensurate reduction in cessation, and this implies that ANS may be able to help the taxpayer externalise the cost of tobacco control. All this does not suggest that ANS should replace traditional tobacco control outright, but rather that by carefully integrating differentially regulated ANS with more conventional tobacco control policies, smokers who have thus far resisted their government's efforts to encourage cessation might finally be persuaded to stop smoking. If our goal is to eliminate smoking entirely, as it should be, we must do more than simply replicate policies that were only partially successful to begin with. Instead, we should regulate all nicotine products according to their demonstrated harms. That would require ANS-led cessation to be integrated with traditional tobacco control policies and policies such as taxation and smoke-free laws to be designed to favour less risky products. A relatively lower regulatory burden for ANS compared with combustible tobacco would make these products more attractive to smokers. Concurrently, maintaining some degree of regulation will help to signal to non-smokers that these products are not intended for them. Evidently, there is a trade-off here, and the optimal set of regulations to both maximise smoking cessation and minimise the appeal to non-smokers will require further investigation. Finally, banning ANS will not eliminate their use, but will deny the regulator an important opportunity to ensure some degree of product safety. As we've seen with Avali, black market products can have significant harms which, while not necessarily intrinsic to the product category, nonetheless require regulation to safeguard against.
Hello, my name is Angela van der Plas, and I am Manager of Real-World Evidence and Epidemiology at Philip Morris International. And I would like to present to you the results of a pilot study in Japan aiming at assessing the collection of data from a sample of subjects visiting a dispensing pharmacy in Japan. Real-world evidence sources are abundant in many countries, but unfortunately, the systematic collection of detailed tobacco product use is overall not guaranteed. Additionally, there are not many recent studies describing the demographic characteristics of subjects being prescribed smoking cessation medication in Japan. This study aimed at evaluating whether the administration of a questionnaire in this population was feasible, as well as collecting their characteristics such as tobacco product use patterns and demographic characteristics. This was an observational, cross-sectional study using a self-reported questionnaire to identify attributes of subjects undergoing smoking cessation treatment in Japan. Subjects were 20 years or older and had been prescribed smoking cessation therapy. The questionnaire contained questions regarding demographic characteristics, characteristics of their cessation attempts, and tobacco use patterns. We used descriptive analysis in this study. Now let's move on to the results. Here you can see the demographic characteristics of the subjects. The majority of subjects were between 30 and 59 years old and were mostly men, about 73.1% of them. Exclusive heated tobacco users were shown to have higher education levels than cigarette smokers, and they were also more likely to be employed in a company than cigarette smokers. 51% of subjects reported at least one disease diagnosis. Cigarette smokers and dual users, those who use cigarettes plus any other tobacco or nicotine-containing product, were more likely to report disease diagnosis than heated tobacco users. Because of the study design, this being a cross-sectional study without follow-up, no causality assessment can be done. Here, we can see the reasons for attempting smoking cessation, with health reasons and saving money being the top two reasons given by participants. When asked about changes in consumption compared to the month prior to deciding to quit, current quit attempt, single product users were less likely to modify their tobacco product use consumption, while over 80% of those using multiple tobacco products had actually decreased their consumption. This observational study aimed to assess the feasibility of collecting real-world evidence data from subjects who were prescribed smoking cessation medications in Japan. Exclusive cigarette smokers differed from exclusive heated tobacco product users in terms of educational level, employment status, and occupation. About half of the overall study population reported having concomitant diseases. This percentage was significantly lower in exclusive heated tobacco product users than in exclusive cigarette smokers and dual cigarette smokers with additional tobacco products. Tobacco product use consumption changes were significant among the exclusive product use categories, with multiple product users being more likely to decrease their product use consumption. Administering questionnaires to subjects filling their prescription for smoking cessation treatments in Japan is a feasible way of collecting real-world evidence data to complement pharmacy data. Thank you very much for listening. Tobacco product use consumption changes were significant among the exclusive product use categories.
Okay, first of all, I would like to thank everyone for the participation, and we enjoy really great jobs. I think we have a lot to think about. Fortunately, we don't have a lot of time, but if someone from the panel can have a comment or a particular question for a participant. Okay, so thank you very much, and we will move forward to the next session. Thank you all.